Hello, I am Dr. Khaja Nazimuddin from Bangladesh, Dhaka. We are with three interesting topics now, most practical topics I should say. And for next couple of minutes we will be listening to them. So may I request the first speaker of this session, Dr. Dhingra, Atul Dhingra.
So before I think he starts, the topic is very interesting. I am Dr. Bhatia from Chandigarh. A 44-year gentleman having type 2 diabetes for 5 years, a lady with type 2 diabetes having insulin requirement of more than 100 units. So with the HbA1c still being 10.5, very interesting situation and very commonly encountered. Now why, multiple reasons for that, and Dr. Atul, and then we take a retrospective.
Good evening, everyone. On the behalf of SPEED team, as one of the organizing members, I welcome you all to SPEEDCON 2022. So, we'll be discussing about a very interesting case, interesting scenario, and a common, not a very common roadblock, but a roadblock which we do encounter in our routine clinical practice. So, in next 20 minutes, I'll try to finish. But if we are over time, just stop me and we can have a discussion after that. So, I'll be talking about causes of increased insulin requirement. I'll be talking about the management and we'll be discussing. So, what actually do we mean by increased insulin requirement? So, it actually means these are the patients who require more than 1 unit per kg per day. It is increased insulin requirement, or it is called excessively increased if it is more than 2 units per kg per day, or if the total daily units required for insulin is more than 200 units. This is the definition that has been proposed by some, but we all know a common name for this. Can anyone here in the audience tell me what is the name for this situation? It is actually insulin resistance we are talking about. So, this is what we will be talking about in next 20 minutes or so. It is common feature of type 2 diabetes, and we know that Alpesh very beautifully in his presentation talked about obesity, which I believe is the genesis of insulin resistance. And to measure insulin resistance, we can use methods like euglycemic insulin clamp, but actually this is not required in routine clinical practice. Clinical diagnosis is how it is made by looking at the patient, looking at the acanthosis, looking at the central obesity, looking at the triglyceride. There you can judge that the patient is insulin resistant. But insulin resistance can be a pseudo insulin resistance. I will be talking about it, and it can be a true insulin resistance. So, what are the causes of severe insulin resistance? We will not be discussing all of these, because if we start discussing, probably I will be the only one who is talking about diabetes for next 2 days or so. So, there are syndromes, these are rare syndromes. We will be talking about medications, endocrine disorders, insulin antibodies, physiological causes, and definitely pseudo insulin resistance. So, first is endocrine disorders, because these things we routinely encounter in our clinical practice. These are the causes, endocrine causes: acromegaly, Cushing syndrome, thyrotoxicosis, pheochromocytoma, and glucagonoma. So, this is my first patient. I'll be taking you through my own patients. So, these are the patients that I saw in my OPD, and we'll be discussing these patients. So, I remember this patient came to me from my neighboring state of Punjab, and the couple was distressed. They just had undergone an abortion. The lady was diabetic. She was on, you can see, Novorapid 20 units thrice a day, Lentus morning 24, evening 20 units. She has been prescribed a GLP-1 receptor agonist, Victoza 1.8, Metformin 2 grams per day, and for her hypertension she was on amlodipine 5 milligram once a day. Her working diagnosis at that point of time was type 2 diabetes, polycystic ovary disease, primary infertility. For her first baby also, she had to take some fertility treatment. She had a history of first trimester abortion. She was obviously obese, but there was something in the physical examination. She had evidence of proximal muscle weakness. She had central obesity. She had abdominal striae, but rest of the systemic examination was normal. So this was the patient when she first came to me. And after looking at her, I asked for an older picture. So this was the patient when she got married. You can see there is gross difference between the two pictures. These were the investigations. Her cortisol was suggestive of high midnight salivary cortisol, ACTH was high. On MRI, we were not able to localize a well-defined lesion. So once we were not able to locate the lesion, so I sent the patient here to All India Institute, and there they did a CRH IJV test, and this test was suggestive of a right-sided lesion. She underwent a surgery. Her diagnosis was ACTH dependent Cushing disease. She underwent transnasal transsphenoidal pituitary surgery, and histopathology was also suggestive of a ACTH staining pituitary adenoma. Post surgery, she was on metformin 1 gram twice a day, and this is her recent picture. Now they are having a baby, and the couple is living happily. So just making the right diagnosis was important in this patient because her insulin was being gradually increased, but still her glycemic control was not that good. But when we looked at the patient, we were able to understand the problem. So this is my second patient, which I saw around 3 months back. He was also referred to me for diabetes control. He has been diabetic for past 3 years. His diabetes has never been well controlled. He gave history of headache, and once I show the picture, you will understand why I asked this history. He gave the history of headache, non-pulsatile, which was not associated with any nausea or vomiting. He did give history of increased sweating, and he also gave history of pain in his bilateral knees. He gave history of erectile dysfunction. Vineet, in his deliberation, told us what we need to do in cases of erectile dysfunction, and currently he was on a premix insulin, morning 44 and evening 38 units. Along with that, he had been prescribed pioglitazone and voglibose, but still his A1C was around 9.5%. So this was the patient when he came to me. So you can see the features are suggestive of acral enlargement, and you can see this is my hand and this was patient's hand. You can clearly see that there is acral enlargement, and we were able to, when we asked him about history of his change in shoe size, he said that every 1 or 2 years his shoe size changes, and he had to remove his wedding ring because it was not fitting his fingers anymore. So we investigated, and his A1C was 9.8, and his IGF-1 came out to be 1028. His testosterone was low, and MRI was suggestive of a pituitary macroadenoma. You can see here a large tumor in the pituitary. He's planned for TNTS, and he'll be getting his surgery done next month or so. So we have to understand that diabetes is not just because of insulin. Actually, it is a combination of other hormones as well. So various hormones like growth hormone, cortisol hormone, all of these hormones actually change a patient's diabetic status. And for this, a very interesting terminology has been proposed by one of my co-speedsters, Dr. Sanjay Kalra, and he has termed it as glucocrinology. That is endocrinology of glucose control. So we cannot just focus on one organ, that is pancreas. We need to look at the patient as a whole, and there can be other reasons for his or her uncontrolled diabetes. What are other causes of uncontrolled diabetes? So medications, especially in this era of COVID, where glucocorticoids have been used, all of us has seen our patients requiring more than 100 units of insulin per day, and still their glycemic control has not been well controlled. So glucocorticoids, but other common drugs are atypical antipsychotics, uncommon calcineurin and protease inhibitors. But if you are sitting in an infection disease clinic and you are looking after HIV patients, these are the common drugs that can be associated with poor glycemic control. And then it is oral contraceptives, which many of our female patients are taking. So this was one of my another patients. 63-year-old female, diabetic past 20 years, referred for poor glycemic control. The glycemic control has been worsening over the past 2 months. Her insulin requirement has increased to around 80 units per day. She was on a premix insulin, and she also had been on olanzapine for her psychiatric illness, but recently she had been started on prednisolone 20 milligram once a day for her skin disease. So, what actually does antipsychotic drugs do? So, this was a meta-analysis that looked into the role of antipsychotic drugs in changing a person's metabolic profile, and they showed that drugs like olanzapine are associated with significant increase in blood glucose levels as compared to other antipsychotic drugs. So, these are various drugs that are used in routine clinical practice, and the amount of glucose disturbance that is caused by these drugs. You can clearly see that olanzapine is one of the drugs that is associated with significant changes in blood glucose levels, but aripiprazole and clozapine are relatively innocent drugs in this regard. So, in this patient also, we reduced the patient's steroids, and we asked the psychiatrist to change the patient from olanzapine to aripiprazole, and gradually her insulin requirement reduced, and the patient is now doing fine. Talking about glucocorticoids, data is now, we have enough data. There was a meta-analysis which suggests that if you are starting corticosteroids in a patient, and if the patient does not have a pre-existing diabetes, there are around 30% chances that the patient will become diabetic. And among these patients, around 19% will continue to remain diabetic even after stopping corticosteroids. So, clearly glucocorticoids, and another important thing is that glucocorticoids are only cause a mild increase in fasting plasma glucose, but they cause a greater increase in postprandial values. So, this is what you should remember whenever you are looking after patients who are being treated with glucocorticoids. So, these are the common glucocorticoids that are being used in clinical practice, and you can see their hyperglycemic effects. If you are using a short acting glucocorticoid like hydrocortisone, their onset of hyperglycemic effect is around 1 hour, peak is at around 3 hours, and the resolution is usually by 6 hours. And as their potency, as their duration of action increases, for example, prednisolone, the onset of action is around 4 hours and the resolution is around 12 to 16 hours. Why is it important to know so? It is important because you can actually choose your insulin according to the type of steroid being used. For example, if your patient is on hydrocortisone, you can just use a regular insulin prior to the meals, and that will suffice. You will not be requiring a longer acting insulin. For intermediate acting insulin, you can actually use an intermediate acting insulin like NPH. You will not be requiring a very long acting insulin. But like most of our COVID patients were on dexamethasone, they actually required a very long acting insulin, and in this regard, newer insulins like U300 insulin and degludec insulin are actually useful in these situations. So, these are the treatment algorithm, how you can treat a patient with glucocorticoid related changes in blood glucose levels. I am not going into the details because it will be time consuming. Now, coming to pseudo resistance. Pseudo resistance may be because poor administration technique, incorrect storage of insulin, or malingering. So, this was a very interesting patient. So, this has been my regular follow-up patient. He is a 40-year-old gentleman. So, probably there is a typo. This was a type 1 diabetic patient doing well on basal bolus regimen. But for the past 15 days, he started calling me again and again that his glycemic control has worsened. His insulin has been increased from around 10 to 14 units thrice a day to 20 units, and basal insulin requirement had increased from 20 units per day to 38 units. Still, his SMBG was suggestive of a fasting plasma glucose of 230 and a postprandial glucose of 350. So, when he came to me in the OPD, I admitted him and I asked, when I went for the rounds, I asked him what had happened in the past 15 days. He just told me that he had come to visit me 15 days back, and after that his sugars have not been well controlled. And when we further inquired, this is how he transported his insulin in the back, in the storage compartment of his scooter. And if you understand where Ganganagar is located, it is the most western part of the country. The temperatures currently in Ganganagar are around 46 degrees centigrade. And he took his insulin in this scooter, and he purchased the insulin from some other pharmacy where he was not provided with the coolant. And when he was admitted, we gave him 20 units, and within 2 hours I got a call from my nursing staff that the patient had developed hypoglycemia. So this is what had happened. So it is important to go deep into your patient's history, and that actually solves your problem sometimes. This is what is needed as far as storage is concerned. Insulin products can be stored at around 2 to 8 degrees centigrade. You should not store below 0 degrees centigrade, because this actually leads to freezing of the crystals, and this can actually lead to air in the cartridges. We need to understand that we have to keep insulin cartridges and pens below 30 degrees centigrade. A good advice is to keep if you are storing it in a refrigerator, keep in the vegetable compartment of the refrigerator. So during transportation also, we have to understand that the insulin is prone to denaturing if the temperature is not maintained, and insulin should not be kept in a locked car with closed windows, because of the greenhouse effect, temperature will increase and this will lead to denaturing. And if your patient is traveling by air, insulin should not be placed in a check-in baggage, and they should be in their hand baggage. So important thing is it should be stored between 2 to 8 degrees centigrade, and there can be multiple methods to do so. So this patient was provided to me by one of the chairpersons, Professor Khwaja Nazimuddin from Bangladesh, and actually this is his patient, and this is another reason for pseudo insulin resistance. You can clearly see that the patient has not been injecting insulin properly. His insulin requirement increased to around 104 units. Fasting was, so this is in millimoles, you can see HbA1c is 11.6, fasting blood glucose was around 13.6. So this is because of repeated injections, repeated intracutaneous injections at the same site. So what actually is lipohypertrophy? It is accumulation of fat under the skin caused by injecting too frequently into the same area. It can become painful, so I am running out of time. I'll just skip these slides. You need to understand how to rotate. These are the sites where insulin can be given, and this is how rotation has to be done. Rotation of the sites is important, and sites used should be at different places. This is another one of my patients, 50-year-old banker, type 2 diabetes, CAD, post-CABG. He came to me with a history of increased appetite, fatigue, and non-specific weakness. We worked out for weakness, we were not able to find out. On premix insulin, insulin has been increased gradually. Sitagliptin 50/1 gram twice daily. HbA1c 8.9%. So he was worried about his HbA1c, that I had a CABG and I am on this much amount of insulin, still it is not well controlled. Fasting 90 to 104, postprandial 210. So in this patient, we actually used a CGMS. And this is what we found. He was having morning hypoglycemia daily, and this was where his sugars were being checked at home, and because of this, his insulin was gradually being increased, and again he was developing hypoglycemia and then again hyperglycemia, and this was causing him to eat more, and these hypoglycemias were the reason for his weakness. So we actually reduced the dose, and this is what happened. The curve became absolutely normal, and his current A1C as per his CGMS is around 6.9%. So increasing insulin is not always a solution. You have to look into the patient, and probably hypoglycemias are some of the reasons of increased insulin requirement. Pharmacological treatment, once we have dealt with all of this, what actually we can do for improving insulin resistance, you can actually use concentrated insulin products. In India, U200 is available. Because of shortage of time, I'll just show you another one of my patients. So when he came to me, he was, you can see, on 260 units of insulin, 130 in the morning, 130 in the evening. Along with that, he was on a combination of glimepiride, metformin, voglibos, and 3 milligram. And his A1C was 9.4%. So we actually discussed about GLP-1 analogs with him, but because of cost constraint, he was not ready to start. We started him on concentrated insulin products, and we also started him on SGLT2 inhibitors. Along with that, I also used saroglitazar in this patient for improving insulin resistance. And on follow-up, currently he just came to me 15 days back. His A1C is 7.2%. He is just requiring around 60 units of insulin per day, and is a happy chap now. So this is the meta-analysis that looked into the role of concentrated insulin products, and they showed that if you are shifting your patient on U500, you can actually reduce the A1C by around 1.6%. So clearly concentrated products also help if you are looking into increased insulin requirement. Metformin we all have been using for insulin resistance. I will not dwell into these. There are data that suggests that metformin can actually reduce the insulin requirement by around 7 units per day. This is another insulin sensitizer, that is saroglitazar, and this study was published in Nature, and they showed that there are significant mean reductions of fasting and postprandial plasma glucose, and A1C is reduced to the tune of around 1.1% if you are using saroglitazar. There is another meta-analysis published from some of my speed colleagues, and they have shown that glycemic control is good, but it may lead to some increment in serum creatinine levels. So you have to use it with caution in patients who have diabetic nephropathy. GLP-1 receptor agonists, again there is data to suggest that if your patient is on high dose insulin, GLP-1 receptor agonists actually help in improving not only A1C but also help in improving patient's weight. I'll just give you one practical tip. If your patient is coming with the problem that he always is hungry and he is not able to control his appetite, and if you have ruled hypoglycemia in that patient, use GLP-1 receptor agonists. It will be useful in those patients, especially obese. SGLT2 inhibitors again are useful, and the A1C reduction is to the tune of around 0.7 to 1%, especially if you are using 300 milligram of canagliflozin. It is especially useful in morbidly obese patients. Thiazolidinediones acts in the similar way. So my final take-home message is, if your patient is requiring high dosages of insulin, rule out pseudo insulin resistance. Look at your patient, pull up his shirt, look at the sides, it is important. Ask about the storage, that is important. Look at the patient's technique, that is important. Then start thinking about other possible diagnoses. If you have ruled out those, think about other endocrine diagnosis, look at the medication box of the patient, that the patient is not on any drugs that is causing the problems, and then you can use any of the methods that I have suggested you for reducing patients' glucose levels. So this is where I belong from. This is the last part of India, that is Hindu Malkot, and you can see the fence, that is Pakistan, and this is India. This is where I belong from. Thank you.
Thank you very much, Dr. Dhingra. It was wonderful. Actually, you picked up on a very important point, that saroglitazar and pioglitazone. Probably we are not, in this era of SGLT2 inhibitor, we are not looking at pioglitazone and saroglitazar. These are drugs which are known to reduce insulin resistance, and especially in patients who had stroke, ischemic stroke. Pioglitazone proactive trial, it's a good drug. Apart from that, a drug which we are very commonly using is levosulpride. Levosulpride is known to increase prolactin levels. Not only it can cause galactorian females erectile dysfunction in males, again because of the increase of the prolactin level, the sugar, the need of OH or insulin may be more. So please take care of that. Thank you very much. Wonderful presentation. Since we are running short of time, we won't go for, yeah, please.
You talked about all these situations like endocrine and pseudo and all. You didn't touch the true insulin resistance due to the, tyrosine kinase or the, mitochondria. I've heard about them when these things are not there. The insulin resistance in the true sense. These are, secondary or
So
Maybe
actually
a
the
word about that.
so actually the last part where we didn't have the time was about the management of insulin resistance when you do not find these causes, because once you have found the causes, you are managing those causes. So these are the drugs when you can actually use in that situation.
Right, thank you.
Thank you.
Thank you. Thank you, sir.